This lung ultrasound module is going to go over B lines. Many of the images and videos are courtesy of the Division of Emergency Ultrasound at Massachusetts General Hospital. And we won't be going over too much of the technique. There is a technique video that you should have already watched prior to this, but just very briefly, in choosing a transducer, essentially any of the low frequency transducers would be acceptable for this applications. Most of our scans are going to be using the curvilinear transducer. And again, in terms of technique, you want the longitudinal scan, scanning the regions of the lung with the transducer marker pointing towards the patient's head. And again, just a refresher, this is what a normal image might look like with the ribs and the pleural line and the A lines underneath it. So in terms of B lines, this is what they might look like. And what you're observing is these long linear echogenic or white lines that extend all the way down to the bottom of the screen. We'll talk a little bit more about that shortly. It's very important that you are familiar with the anatomy of the lung, and specifically with respect to the secondary pulmonary nodule. And as you may recall, these are essentially units of the lung, and what you have here is the lobular artery and the lobular bronchiole here supplying the lung, and separated by the interlobular septa, which actually contains the lymphatics. And here's another illustrated diagram of what that might look like within the lung parenchyma, and you can see these interlobular septum right there. Why is that important is that it's because B lines are felt to be related to interlobular septal thickening. And here's a CT image of a patient in congestive heart failure or pulmonary edema. What you're going to see are these very well-defined interlobular septal thickening that you can see on CT. And B lines, at least, are thought to be related to interlobular septal thickening. A lines, in our last module on technique and normal findings, we've gone over how A lines are formed, and essentially they are trapped sound waves between the skin and the pleura. And what that gives you is recurrent linear lines that go distal to the pleura that represent A line. In the case of interlobular septal thickening, and what you have here is a very localized area where sound waves are trapped between the pleura and the interlobular septum, which is thickened, and it becomes now very reflective. And it traps sound waves and therefore places multiple horizontal lines all the way down the screen like this. These are essentially localized reverberation artifact. And again, I think you can kind of appreciate why you might see that. And if you have linear localized interlobular septal thickening here, if you place a transducer here, you can see why sound waves might be trapped and get reflected. And again, the important thing here is that lung ultrasound is really imaging the very periphery of the lung. So we won't be able to make any comment in the central aspect of the lungs, but as long as you have findings that extend out to the periphery, such as here, here, and here, lung ultrasound is quite equipped to detect those changes. So here's another video of what B lines would look like. And what clearly defines B lines are the following characteristics. Okay, one is that it needs to start out at the pleural line. Okay, so you can see if you trace these linear artifacts, they go all the way out to the pleural line. Second is that they actually move with respiration. You can see as the lung sliding occurs, as the patient takes a deep breath in and out, you can see these movements of the B lines. Third characteristic is that they actually go all the way down to the bottom of the screen. Okay, and the reason why that's important is that it will distinguish B lines from another reverberation artifact that we'll discuss shortly. And specifically for our criteria, we would like a very, very deep scan. And for now, 18 centimeter is what you should be aiming for, that you have sufficient depth to make sure that the screen, the B lines do extend all the way to the bottom of the screen. Make sure that you have sufficient gain on so that you can actually see these lines. By definition, if you have more than 3 B lines between 2 rib spaces, so if this is one rib and one rib, so between the 2 ribs within this 1 interspace here, if there are more than 3 B lines that you can identify, it's considered pathological. So what I was describing earlier is that you have this other type of reverberation artifact that are called Z lines or Z lines in Canada. And what you see here is really, you can see these reverberation artifacts, but they peter out around 3 or 4 centimeters or so they don't actually extend all the way down to the screen. And they're actually not of any pathological consequence. So at least as of now, there's really not known to have any clinical significance at this stage. What are some of the differential diagnoses for being able to observe pathological or significant number of B lines? Well, think about anything that will make your interlobular septum thick. Okay, so any interlobular septal thickening would provide B lines on ultrasound. And that could be in the form of fluid or infection, and any scarring issues that you might have, or lymphatic problems with malignancy. Any of these things, anything that can make your septum thick can cause B lines. So rather than being too prescriptive about your extensive list of differentials, sort of think of them as opacities on chest X-ray. So what would your differential be if you have unilateral opacities versus bilateral opacities? Using the same principle, you can sort of decide on a appropriate differential diagnosis for having observed B lines only on one side of the lung versus being able to observe B lines in both lungs. So unilateral processes are infection, contusion, PE, fat embolism, etc., cancer. Bilateral processes would be things like ARDS, or if you have bilateral infection, pulmonary edema, etc. And certainly it's not an absolute cutoff. You can have unilateral pulmonary edema on occasion, and certainly you can have malignancy in bilateral in both lungs. It's beyond the scope of this talk to teach you all the medicine, but really use the medical knowledge that you have. Your differential may differ depending on the acuity of the presentation and specific patterns of its upper lobe versus lower lobe. Severity of your B lines can also be graded somewhat. So here we have fairly normal looking lung on the far left hand side of the videos there. In this section underneath here, you have just considered pathological B lines, but you really just kind of meet criteria of having more than 3. And then you can moderate, where you actually involve more than just a single interspace. You actually see these involvements, B lines in multiple rib spaces. And then in a very severe setting, you might not actually see discrete laser-like lines down the screen, and they may actually be confluent in appearance. What you're really looking for is that movement right here that you can see as the patient takes a breath in and out. You can see the movement of that confluence. So the minimum criteria we should go over is that you really need to have sufficient depth in your scanning. You need to be using a low-frequency transducer for that reason. You really should label the zone number that you're scanning. You should ideally use a lung preset, or in the minimum, remove the tissue harmonic imaging or any post-processing capabilities that your machine has of getting rid of artifacts, because we're actually very interested in artifacts in this case. And make sure you have sufficient gain so that you can actually see the B lines. You do want to make your pleural line as echogenic as possible. And by that, you generally requires that you kind of sweep a bit to make sure that you're imaging your pleura at 90 degree, as perpendicular as possible. And then you must clearly demonstrate, or at least have some sense of which one is the pleural line. And ideally, if you can demonstrate the rib shadows, then it's very helpful. You should show that the B lines are moving with the pleura, and that more than 3 would be considered a positive region. You should really try to scan a minimum of 4 zones within the lungs. And again, as a reminder, these are the zones that we're discussing: zone 1, 2, 3, 4, 5, 6, 7, and 8, and posteriorly right side and the left side of the patient's chest for those who can sit up and have an examination posteriorly. Okay, so the take-home points for this module is that really B-lines are artifacts that you're interested in looking at, and we think that they likely represent interlobular septal thickening. A positive exam is having more than 3 or more B-lines between 2 ribs, and then make sure you have sufficient depth and gain when you're actually imaging for B-lines. Okay, thanks for tuning in, and this is our webpage. If you have any questions, you can contact us through that email as well too.